Good morning. I call this meeting of the Public Accounts Committee to order. This morning we'll be talking about physician services. We have with us the Department of Health and Wellness and also the Nova Scotia Health Authority. Just a reminder for everyone to ensure that your phones are on silent so we don't have interruptions. And we'll start with introductions, beginning with Ms. Lonis-Croft.
Good morning. I'm Suzanne Lonis-Croft, constituency of Lunenburg.
Morning. Thank you for being here today. Bill Horn from Waverly Fall River Beaverbank riding.
Ian Rankin, Timberley Prospect.
Good morning. Welcome. My name is Tim Houston. I'm the MLA for Pictou East.
Good morning. Dave Wilson, MLA for Sackville-Cobequid.
Good morning. Lenore Zan, Truro, Bible Hill, Millbrook, Salmon River.
Alan McMaster, MLA from Inverness, your chair. We also have the Auditor General's office with us this morning.
Terry Spicer, Deputy Auditor General.
And we'll begin here with Mr. Elliott.
Kevin Elliott, CFO at Finance and Treasury Board.
Victoria Goldring, Executive Director, Health Human Resources Supply Management for the Department of Health and Wellness.
David Bartol, Senior ED, Corporate Services and Asset Management, Department of Health and Wellness.
Good morning. Denise Perrette, Deputy Minister, Health and Wellness.
Good morning. Janet Knox, President and CEO, Nova Scotia Health Authority.
Lynn Harrigan, Vice President of Medicine and Integrated Health Services for the NSHA.
And Tricia Cochran, VP Integrated Health Services, Nova Scotia Health Authority.
Thank you. We have lots of people here today. We have two offices with us, and I'm not sure who wishes to go first, but there's an opportunity for opening comments. Will we start with the Deputy Minister of Health? Okay, Ms. Perrette.
Thank you very much, and thank you very much for the invitation to be here. I think the topic of physician services, and more specifically access to physician services, is an important one, and so we really appreciate this forum and the opportunity to address the questions that you might have. I'd like to make a few comments, sort of touching on three things. I want to talk a bit about the context that we understand this issue plays out in. Talk a bit about numbers, because there's been lots of numbers reported by the media in the last couple of weeks, and a bit about the initiatives underway to address supply issues. So let's talk context. Access to physician services isn't really a Nova Scotia issue, it's a Canadian issue. Every province and territory in this country is wrestling with how to improve access to physician services. And they're doing it in a context where health systems across the country are in transition. And the factors that are pushing us into transition are economic, they're demographic, they're changing expectations of the public, their demands for greater accountability, and importantly, they're emerging health research and established health research that tells us we need to focus on how to improve health outcomes. We need to focus on how better to serve the population of our provinces. And you're probably all familiar with, the general statistics that have been quite topical over the last couple of years. Canadian health systems are costly. We spend more per capita, and we do not get equivalent results. We do not get the results you'd expect from that investment compared to other countries that have publicly funded health systems comparable to ours. And so in response, we have health systems across the country under pressure to transition. And that transition in its simplest form is moving from acute care to community, moving from a focus on system needs and interests to the interests of individuals, families, and communities, moving from a system that is highly fragmented and disjointed. We have a lot of independent providers that operate on their own to a system that is integrated and coordinated, because we know the evidence tells us this is how we'll improve health outcomes. So very briefly, and it's important because the shift goes beyond just physician services. We have a system of Medicare in the country that's served us well, we're proud of and we should be proud of, but it is a very deep and narrow system. You get universal coverage if you're in a hospital or if you see a physician. When we say we don't compare well on health outcomes to other countries, their systems are comprehensive. And you know the gaps in our system. We don't cover dental care. We don't have universal drug programs. We don't cover a lot of mental health providers or physiotherapy or the like. We need to shift the system in this country from not just the focus on acute and medical, but into a comprehensive, well-organized system. And there are numerous studies that show a growing consensus that individuals experience better health outcomes and they receive better care, they are happier when care is provided through a collaborative team environment that uses a range of qualified health practitioners working in partnership. And the beauty about this is not only do health outcomes improve, but health system providers are better supported and they're happier. And what you will hear is that we have a new generation, if we're talking about physician services, we have a new generation of physicians that are graduating and they don't want to practice in solo practices. They are trained in collaborative practice and they want to practice in team environments. So we need to utilize all of our qualified resources if we're going to talk about access. And there's some stunning statistics. Dr. David Naylor did a really important report that if you haven't seen, I would refer you to in 2015 to the Federal Minister of Health. And one of the comments he makes in the report is that we have known, there have been well-established studies since the early 70s that qualified nurse practitioners working in collaboration with a family physician could do up to 70% of what the physician could do without a difference in patient health outcomes or satisfaction. That's important. And it's important for Nova Scotia because you have a very vibrant and dynamic nurse practitioner population. You also have a wonderful emergency health system, and it has a role to play in primary care. You have led the country in EHS, and you are the envy of many provinces in what you're doing in community paramedicine. And that supports care most recently by supporting the care for seniors in long-term care or in patients that are in palliative care. And these are important, valuable resources that are a wonderful foundation in this province. So all of us, the Department and the Health Authority, are focused on physician services and how to improve them, but in a context where we take advantage of all our effective resources. Very briefly on numbers. There have been a lot of news reports of lately. I seem to read them every day, and a lot of numbers in those reports. I want to just say a few things about our reference point, which would be primarily the Canadian Institute of Health Information, and there's important stats that I think we should be aware of. In 2015, so the Canadian Institute of Health Information, or CIHI as we refer to it, monitors physician services for a number of years, so they have a trend analysis. In their 2015 report, they noted that Nova Scotia had one of the highest physician to population ratios in the country. Between 2010 and 2015 in this province, the growth in family physicians was over 15%, specialists was a bit higher than that, and the population growth was just under 1%. CIHI noted that MD graduates across the country is strong and that there should be a supply of physicians throughout the country for the next couple of years, that we do not have a supply issue in that regard. And just yesterday, the report that I read in the media referred to Stats Canada information based in 2014 that said Nova Scotians, 89% of Nova Scotians had access to family physicians. That compares relatively favorably to Canadian averages, which usually peg access at 85%. And I know, and we all know, that if you are in the 10% or so that don't have access, if you're an individual or a family seeking a family physician right now, statistics are cold comfort. I can talk about positive supply statistics, or I can talk about evidence on collaborative care, and that doesn't address your problem. So what we have done and what we have underway are a number of initiatives to address the problem. And they range from the major initiative of consolidating the health region, and the Health Authority will speak to the advantage that that gives this province by simple things, even removing just the competition between 9 competing resources that would try to outbid each other. We have in this province, and we led the country, in 2012, a physician services resource plan was put in place, a 10-year plan, and it's updated every 2 years. That was a significant leadership component of how resource planning and health provider resource planning is underway. We offer incentive programs to move physicians into communities of highest needs. We have a medical school in this province that's on the job on this front, that's training physicians in collaborative care and encouraging us to place residents and third-year students in community of high need, because the evidence is so compelling that if you train there, you stay there. We also have an initiative coming out of November on the 811 line that gives us real-time data on who's looking for a physician. So I will end there. I appreciate the ability to make opening comments, but I will say this. There's a lot to be proud of in this province. There's some really good foundational elements. And on a personal note, it's one of the reasons that I was convinced that I should come here. I think there's good work to do. Thank you.
Thank you. Ms. Knox.
Good morning. Thank you very much for the opportunity to be here this morning and to be here with my colleagues from the Nova Scotia Health Authority and the Department of Health and Wellness. Nova Scotia is in the midst of a province-wide health transformation, and this work really is about ensuring each person in our province has access to appropriate care in the right place by the right provider at the right time. Doctors are an essential and a valued part of our health system, and I want to echo the comments of our deputy. We are competing nationally and internationally for this valued resource. And we know, having been here for some time, that these issues that we have are a couple of decades old. Addressing our issues now require new and different strategies to get different results. That is what we need for the people of our province, different health outcomes. So we are planning for the future and a new model, but at the same time, we need to pay attention to the access issues that exist today. And as our deputy has said, the future is improved access to primary collaborative care in local communities, and she's well described that. I'd like to echo, we believe that outcomes for our population do matter. Evidence does matter. It's very important. We have been steadily putting more and more resources into healthcare for decades without changing the health status of Nova Scotians. Removing the silos of the former districts, consolidating data from a provincial perspective so we can see where the hot spots are for our province, and creating province-wide processes are how we're going to get to a better place. So we are doing this work as a province, and we know the literature tells us, and the evidence of our colleagues internationally show us that this can result in improved care and improved outcomes. And it also can result in improved recruitment and retention of physicians and team members that we require to support our population. We know now more about our health system than ever before. Nova Scotia was the first province to do this comprehensive physician resource strategy, and how we use that is as a planning tool to help us forecast where physicians are needed to ensure the right number, the right mix, and the right distribution to support our population needs. Our deputy has talked about where we sit in the country in terms of how many physicians per capita that we have. I'd also like to say that since the beginning of Nova Scotia Health Authority, we have welcomed more than 170 doctors into this province. We've been collecting our data to help us understand the vacancies in our province as part of a targeted provincial recruitment strategy. We are no longer competing as 9 districts with our IWK colleagues for these resources. And we're now able to match doctors to communities in need in a way that will improve the retention of those physicians in that community. We know that the key element of successful recruitment is the practice model. Our doctors are telling us that. And new graduating doctors want team-based support. They need and want and describe the need for mentorship, and they like this team environment. We take advantage of the provincial incentives that are available to us to recruit doctors to areas where they are needed. This is very helpful. We also work closely with the Dalhousie Family Residency Program, and 90% of our residents who train in local communities stay there. And we know from them that community support is crucial, and I want to say a word about that. We have learned over our years that the most successful activities in terms of recruitment of physicians, and I'll give you an example of where we have done some focused work, would be the town of Middleton, where we partnered with the town to create a tone of optimism and welcoming that paired the jobs that we had with a place that a new doctor would like to come with their family to build their lives together. And the doctors told us that they were attracted to the collaborative practice, to the mentorship opportunities, and the support and engagement of the local community was a crucial element to that success. So these recruitment challenges are not unique to healthcare. We do need to promote Nova Scotia communities as destinations of choice for our young and our older professionals. We need the entire community working together to create the winning conditions for successful recruitment and, most importantly, for retention of our practitioners. We will continue to recruit doctors and build interdisciplinary teams that improve care and access for Nova Scotians. We know that more than 25,000 Nova Scotians have enrolled in our Need of Family Practice registry, and we're very focused on that. We acknowledge that some of those people have complex conditions that need continuity of care now, and we must do something about that now. And so our focus, knowing this group, is on an interim strategy that will help us ensure that these high-needs patients receive the care they need while we're helping them find a continuing of care with a local practice. So the issues are complex. Some of our citizens have a doctor but wait too long for an appointment. Improved access to primary care means building teams that provide coordinated care across the individual's lifespan. Last fall, we were very pleased to receive $3.6 million investment in primary health care from our Department of Health and Wellness to add more than 20 new nurse practitioners and family practice nurses. In this process, we've identified priority communities, and based on the need and readiness of those for these positions. And we worked with our physician community to identify those who are interested, and we had 45 practices respond. We are now working with the selected practices to finalize arrangements and are hiring new staff members. Integrating these resources into community practice will increase access to care by offering same-day, next-day access, as well as evening and weekend options, in addition to offering comprehensive care for patients. We expect that this change alone will open up more than 14,000 spaces in areas of the province that we've identified that most need them. So as we work to transform how Nova Scotians access health care, we know that community-based collaborative models are the foundation for our system as we go forward. We know that we have to change the way we provide inpatient hospital coverage in smaller centres throughout a coordinated provincial hospitalist strategy. We also have to work with communities and acknowledge that recruitment of a professional into a community requires a partnership with the health system and the community. There are challenges, there always will be, in this very complex system. We need the courage to make the changes that will improve the health outcomes for our population, and we remain focused on making sure our resources go where they are most needed to enhance the care and health of Nova Scotians. Thank you.
Thank you. We'll begin with Mr. Houston for 20 minutes.
Thank you, Mr. Chair. Thank you for the opening comments. I do want to start with the report that the Health Authority commissioned on mental health and addiction services. It was received by the Health Authority in October 2016, and it recommended the closure of inpatient detox units in Pictou, Spring Hill, Strait Region, and some of the Cape Breton beds. I'd just like to ask Ms. Knox, is the Health Authority going to act on those recommendations?
Ms. Knox?
Thank you for that question. And you probably heard some of our conversations this morning with our Senior Director of Mental Health and Addictions. We have, as we became Nova Scotia Health Authority, our challenge and our mission is to provide the best access to service to all of Nova Scotians. So as we go forward, we have to remind ourselves we need to use the best evidence that's available to us, but we need to make a made in Nova Scotia solution. And when we make decisions about, as we go forward for mental health and addictions, they need to be tied to what's the resources for primary health care in the local community, what are the access to the other services that promote and support some of the work in mental health and addiction. So what I would say to you is, this is piece of the evidence that our team with local citizens will use to make decisions together. So that is how we use the data.
Okay. When you had that report since October 2016, do you know how much that report cost?
I believe that the report, that work costed $185,000, $115,000 of which was funded through a national project that Nova Scotia was part of.
Okay. Was it sole sourced, or was it put out for tender, or?
No, I'll have to get back to you on that one.
Okay. Okay, so you've had the report since October. You haven't decided whether or not you're going to act upon it yet. Is that a fair summary?
Well, the ongoing work that we need to do has to be in combination. So no, you're asking me, have we decided, are we responding
Okay, so you're
to all
still
of the
thinking about closing
recommendation?
those units. You haven't decided whether you close those units
We
or not.
have to look at the whole picture, decide what the comprehensive plan is. Yes, it can't be a one-of decision on one piece of the program.
Okay.
Yeah,
So the
yes.
consultant wasn't asked to provide, they weren't asked to provide a plan. They were asked to provide just something in isolation. That's just one piece of information, I guess. Is that?
That would be one piece of the information that the consultant was asked to look at. That consultant helped us do literature reviews, bring together a meta-analysis with the best evidence around the country and the world.
So that consultant looked at whatever they looked at, and then they made the recommendation that these units should be closed. And then when that's received, you say, well, that's interesting, but there's also these other factors that we need to consider that the consultant wasn't asked to consider?
Absolutely. There are more pieces of action that we need to take care of.
Okay.
And
How soon would you think you would decide whether or not to, what you're going to do with those units? Would that be a budget item for this year, or?
Our approach in supporting and going forward is to really look at community-based services and pay attention to, as our deputy has described, what we've learned from others across the country and, in fact, internationally. We need to look at what's the services that are available in local communities, and moving to community-based services and really helping people have access to those in their local community is the first step, and then you layer on what we traditionally would have described as the hospital system that we currently have.
Based on that, I'd say you're not going to follow the recommendations. This community-based services wouldn't, to me, that doesn't imply taking services out of a community, which is basically what the consultant recommended, is it not?
I think you're, with respect,
to
I think
close the detox units in Pictou and Spring Hill and Strait and stuff.
But that doesn't mean that the service wouldn't be provided on a community-based service in the local community.
It'd be a different service in the community, is what?
Yes, and so I come from a long background in the health system, and I'll give you an example. I began my work as a pediatric nurse, where we would have a 300-bed hospital. Now we have a 100-bed children's hospital. When I began 3 decades ago, nobody came to the ambulatory clinics in a children's hospital in this country, and we probably have between 500 and 1,000 visits a day.
Okay.
So it's a very different way of providing services.
Sure. I mean, and sometimes change is good, but I can only, my only example is the short stay unit in Pictou County, which was closed for 90 days back in August 2015.
Yes.
I know that the department and the health authority would say things are better right now in Pictou County. They're not better in Pictou County. So when I hear about these types of transitions and stuff, I refer to that example. But I'll leave it at that for now. You're thinking about what to do with that consultant's report based on other factors. I do want to switch to, maybe we'll ask the deputy. I did hear some statistics in there, but I didn't in your opening remarks. But I didn't hear some of the statistics that I was looking for, so I'd like to ask if those are available now. How many practicing family doctors do we have in the province of Nova Scotia? Or you might call them primary health care professionals or whatever, but I want to get away from the term physician because it's too misleading. There's too many specialists and academics and stuff. I just want to focus on practicing family doctors, and I'll use that term if that's okay. How many of those do we have in Nova Scotia today?
And I'm just going to look at Victoria to give the...
Ms. Goldring?
So family physicians, our latest numbers, 2015, it's 1,241.
1,241, and that was in 2015?
Yeah.
And do you know how that would compare to like 2014?
I can tell you how it compares to 2010. So in 2010, we had 1,077. So it's an increase of 15%.
Okay, so That's over a 5-year increment, so is that only looked at every 5 years?
Well, it's based on CI-High data.
Okay.
So we look at it yearly. We update it yearly. We provide the information yearly to CI-High.
But the department is paying the doctors in the province, are they not?
Of course.
How many practicing family physicians is the department paying right now?
If you want a valid statistical number, that's the number that I gave you.
But that's, I'm just curious about right now with respect, like this is now, we're in 2017.
So
They probably got paid, what's the date today? I don't know if they get paid every 2 weeks or whatever. They get, I don't know how often they get paid, but they recently got paid. I'm just wondering how many we paid.
So we often talk about the full number of physicians, so including specialists, and the number that we use is 2,602 physicians
Okay. So
that we are paying.
many of those are not practicing family doctors, so it's not a number you have to hand.
Those are practicing family physicians and specialists.
Right.
It does not include residents,
Right.
who we also pay.
Okay. You can't split that between specialists and practicing family physicians.
I can tell you, so I'll give you the 2015 number. So it's 1,241.
Okay. So I guess no real answer to that one, which the second question I was going to ask, because no, it's what I need to know is, I believe there's a shortage of family doctors in the province. And I believe that based on the number of people that I know in my constituency office, in my friend circle, in my family, that don't have a family doctor and don't have any prospects of getting a family doctor. I'm just trying to figure out how many more family doctors do we need in the province. But I guess if you can't tell me how many we have, you probably can't tell me how many more we need, right?
Well, with respect, I did tell you how many we have. And you asked how many do we pay, and I answered that as well. So we have as our deputy minister,
sorry, Mr. Chair, I'd like to clarify.
Order.
A very
Order. Mr. Houston did ask for a specific answer. This is the Public Accounts Committee of the Legislature. This is the only place where Nova Scotians can hear answers about past expenditure of government. Mr. Houston has asked a question. There has been an answer provided. It hasn't been exactly what he has asked for. Can the witness work to provide an answer to the committee sometime at a date in the near future? Ms. Goldring?
Is it possible to get the question in writing? Because I'm not.
We can pull the transcript, or Mr. Houston, you can rephrase the question now, and we can have the clerk send it in writing to the department.
Thank you.
Mr. Houston?
Thank you, Mr. Chair. I'd just like to ask a very specific question. Practicing family doctors in the province of Nova Scotia, not specialists, not academics, practicing family doctors, people that are actively seeing patients in a clinic somewhere. How many practicing family doctors do we have in the province of Nova Scotia? If it's a number we don't know today, then I'll take that as an answer.
I'll turn it over to my colleague from Nova Scotia Health Authority.
Okay.
So Ms. Harrigan.
Okay. Dr. Harrigan, sorry.
Sorry, Dr. Harrigan.
Not that it means much. Anyway, so these numbers are very hard to track, and I think part of the reason that they're hard to track is the diversity of family practice. And so 20 years ago, if you train as a family doctor, you opened a practice, you set up shop, and you may have done other things, but your primary base was the office. And that has changed dramatically. So you now may actually exclusively be an emergency room physician, or you may be a sports medicine physician, or you actually may work as a hospitalist. And so when you actually look at the numbers, you're right, it's very difficult to say, is that someone working in their office? But through the physician resource planning document, we actually have an estimate of that. It's physicians working in offices. And in 2012, that was 780 physicians working in practices. And that at that time, we knew that there was an incorrect ratio between primary care specialists and other specialists
okay,
were higher.
Mr.
But I'll
Chair.
tell you the value this year. So the value this year is 808 family physicians working in practices, so that's an absolute increase. And based on our physician resource planning document tool, it shows that we have now leveled that playing field. So the number of family doctors that we have working in offices in Nova Scotia actually is at the number that we predicted it should be. So the question then to ask, and I don't want to usurp your questions, but of course, is then why are there people without family doctors? We have adequate numbers. So that's a question we have to, so the answer is not necessarily more, it's maybe changing the way we provide care so that people can get access.
Okay. I think it's overly complicated. It's a simple question. And maybe it's because I'm an accountant, but people say follow the money. You know how many doctors are being paid either fee for service, it's obvious. You know how many people, how many doctors might be in a collaborative practice on an alternative payment plan or whatever that arrangement is. So I'm quite surprised that it just took up most of my time to figure out how many doctors there are in the province, but surprised is the word I'll use, but I have other ones. We have too many people in the province that don't have a doctor. That's a simple reality of life. In Pictou County, I listened to some members of the Department of Health Authority present to Pictou County Council on Monday night. They were asked how many people in the county of Pictou were without a family doctor, and they were told 1,600. It's way, way more than that. And everyone in Pictou County knows it's way more than that. And they were asked, what's the number of 1,600? They said, well, that's the number of people that called the 811 number and registered. But that's not a good way to determine the need in the province. So I'm probably going to move on to my questions, but I'll leave you with this thought. If you don't actually have just like that, how many doctors are seeing patients in the province today, and you don't have an accurate number of how many people need a doctor, we're never going to solve the problem. And I was hoping that we'd come here today and we'd hear some just quick, great, we're ready to talk about this and we're ready to figure out how we're going to address it. But we just used all this time to try and figure out how many doctors are in the province, and that's, to me, it's pretty unacceptable. So I would say that my understanding of a collaborative practice, and it sounds like a great theory, the collaborative practice, doctors seem to like it, patients seem to like it for the most part. But my understanding of that was when you're a patient of a collaborative practice, you're a patient of that team. And when a doctor's out or whatever the case may be, the team kind of picks up. Sometimes the team is a full complement, sometimes the team doesn't have a full complement, but that's the value of a team. So in Pictou County, at the clinic on the west side, you're probably aware that they're down a doctor. Patients are being discharged from that clinic because their doctor is no longer there. And that was kind of contrary to my understanding. My understanding was you had a team of physicians, and now that one specific doctor's out, you're gone. And again, at County Council, they asked if people were being discharged, and the answer was not to the knowledge of the health authority or the department. I forget who actually said it, but I guess I'd ask Ms. Knox, are patients, did you know that patients are being discharged from the Westside Clinic because of the doctor shortage?
Ms. Knox?
Thank you for the question. We are very much aware of the situation there in that clinic, and I think I'll ask Tricia Cochran to talk a bit about that clinic. Your question, you're asking, are we aware? We are aware that there are challenges there. Did you want us to talk about?
Well, are you aware that people are being discharged from that clinic? They're being told you don't have a doctor anymore.
Ms. Cochran?
So I am hesitant to get into a particular situation. It's delicate. The work that is being done to try to address the patient needs in that community, our staff are working with the physician to try to address that issue.
I guess what I'm going to get to is there's a policy issue here. And my understanding of the policy issue was that once you're a patient of a collaborative practice, you're a patient of that collaborative practice. Is that not the case?
That is our vision for where primary health care teams are going to be into the future. What we're dealing with now is a history of 10 years of evolution in 9 different districts that approached what the requirements and accountabilities are for that primary care team. We are now in a position where, as one province, we can be working on not 9 different ways, but one way. And when you sign up to be part of a collaborative team, an example of that would be the new providers that are coming in, the practice nurses and nurse practitioners, as they're joining teams. One of the deliverables will be access, and that team will be owning the practice population. But that's not been in the past everywhere.
Okay, so when doctors sign a contract with the province, was there nothing in those agreements for, is there anything in the agreements for doctors that are, let's call them salaried doctors and alternative fee arrangement doctors? There's no, so like something fell through the gaps there where the people were informed that you're part of a collaborative team, but they really weren't. They just happened to be in the same building is what it seems like to me. And I wonder if maybe the Auditor General did a report in May 2014, so it's 3 years old now. He raised a lot of concerns with doctors on alternative funding arrangements, not being policed, let's say, for lack of a better word. And he had pages and pages at the time of doctors on alternative funding arrangements that weren't seeing the number of patients that their contract said they should. To me, this is almost the same thing, just on a different level with the collaborative. So I guess I'm surprised that 3 years after the Auditor General raised these types of concerns, this is happening in real time, and everyone's taken aback. They're really taken aback that they're calling for an appointment and saying you don't have a doctor. So I understand the pressure that the doctors in that specific, and this is a significant policy issue. There's a problem here with the way this is being constructed, and there's many collaborative practices around the province. They all have the same problem if this is a symptom of it. So I see the deputy wants to chime in. I'll be happy to willing to let her speak.
Ms. Parrott?
Thank you. And I'm going to thank you for the question, not in a superficial way. I do thank you for the question, and I'm quite sincere. And that's why I made the comments I did at the beginning about context, because it is a policy issue, and we are in transition. And transitions are not always easy because they require structural changes and cultural changes. So I think having a forum like this that points those out, that holds our feet to the fire, is critically important. I want to say 2 things. One of the changes, the structural changes, and there's an excellent article in the Globe and Mail quoting Professor Colleen Flood, February 17th of this year, who talks about the challenge of family practitioners, physicians, who have largely practiced autonomously. They determine when and where to work, how to work. And to make that shift, even to the APP environment, is a significant shift. It's a cultural shift. And it's not going to happen overnight. So I agree it's a policy change and one that we have to be resolved about. But it's not necessarily going to be an easy change, and it requires a lot of transition. But my second point is, and I am not diminishing the fact that people are looking for a family physician. And I know that that's an important issue. So I know it's cold comfort. But Nova Scotia has less of a problem on that front than the other provinces for the most part, and has foundational pieces in place that really give us encouragement that we are going to move the marker on this one. And forums like this are going to help us.
Mr. Houston, you just have, there's just 5 seconds left, so we will have to move on to the NDP caucus. Mr. Wilson, 20 minutes.
Thank you, Mr. Chair, and thank you for being here today. I want to welcome the new Deputy Minister to Public Accounts, and I'm glad that the initiatives of the former NDP government convinced you to come to Nova Scotia. You know, we worked hard. We worked hard on ensuring that paramedics work extremely hard in this province in a number of capacities. We worked hard on ensuring the rural residency program is successful and was initiated in this province. We worked hard on ensuring collaborative approach to healthcare, like the CECs were initiated in the province, and I look forward to working with you over the next number of years. So of course we're here on the topic of physician services. Get right into it. How many new, and it's really around family physicians that have been kind of getting the news media lately, especially with the current government's commitment to have a family doctor for every Nova Scotian. So how many new family physicians have we attracted to the province in the last year. I would hope that we could have that data, and I don't know who amongst you all may have that, but how many new family physicians have we attracted to the province in the last year?
Dr. Harrigan.
So I can give you, yeah, so the number is, since July 2015, is 71, and for this past year is 36.
So since 2015, 71, since this year, 36.
Yes.
How many physicians have left, have retired, have taken leave, have passed away, have closed their practice since 2015?
So I'm going to have to look at our, so that is a number that has not always been tracked, but we now have vacancy numbers, and so if I can just pull my binder, I can tell you, I'll have to add that quickly. I know there are 27 in Central Zone.
27 in Central Zone.
Yep.
So and that's just in the last year?
No, that's since we
Since
started to record it, so that would be since April of 2015.
April of 2015. So that's pretty
I
close.
should state that those are current vacancies that haven't been filled. So we've actually filled a fair number of those. So those are the current vacancies that have not yet been filled.
27, but you couldn't tell us how many physicians retired, are ill, have passed away, because I've experienced that in my own community where we've unfortunately lost a physician.
I can get that number for you, but I don't have it on my fingertips.
So I would like that, officially request that. So a list of new physicians that came to the province over the since 2015, hopefully. A list of physicians that have left or retired or who no longer practice. That would be very helpful, because often when we are engaging government, especially elected officials, they're very quick to give us the number of new doctors, and especially in Cape Breton, where there has been a significant loss of a number of physicians, and the caseload of those physicians are just staggering, and we know that the net gain is not in a positive number. So I would appreciate those numbers, and I look forward to seeing those. One of the areas, of course, of concern to many of us is of course access to care. We've heard from the government, from the Department of Health, around the collaborative practice and how we need to move towards a collaborative approach to delivering primary health care, and I couldn't agree more. But there's a lot of steps that need to take place in order to have that to be successful. And I look at the experience of collaborative emergency centers. There's a number of things that need to happen in order for that to be successful, and I still commit and say that they're very successful in the communities that they are currently running in, and a number of things that need to happen. First of all is a negotiation with physicians in that area, try to get them on board to understand the new model of care that is being presented. The other one is consultation with the healthcare providers in that community so that they understand this new model of care and how is this going to be transformed into improving care. But I think the most important thing that we learned about initiating the collaborative emergency center model was community engagement, community consultation. You had to go into those communities to explain the new model, explain how things are going to work, explain how you'll receive better health care. So with this collaborative practice model that we've heard about, that the government has been saying for 3 years now that we're going to see here in the province, we understand the negotiations with the doctors to a certain extent has been finalized. There's a contract with them. So a couple questions on that. Interesting to find out that the negotiations for that happened not within the Department of Health, but through a third party, through hiring a consulting firm or McGinnis Cooper. Could you provide me the cost of that, of utilizing, and I know the deputies knew, but there's other support staff from the department, how much that cost the department to go outside, and maybe why the department, why the government chose to go outside to negotiate with the doctors when that has been happening within government for as long long as I can remember. So cost of that consultation or how much that cost, and why did we go outside externally to negotiate with Doctors Nova Scotia, for example?
So thank you for the question, and if you don't mind, I'll get you that information in writing.
I appreciate that. The next step is, of course, the consultation with healthcare workers. That happened with the Collaborative Emergency Centers. Has that happened with nurses and those who might come together and work in a collaborative approach? And if that has happened, who have you been discussing that with, and what has been the result of that?
So I'm going to respond just briefly and on a more general level, and then ask the health authority to respond more specifically, because it's an important question, and it's one that is quite exciting, quite frankly. We're talking about transition. We're talking about moving to collaborative care. We're talking about structural and cultural change. And what is so reinforcing is, if you talk to health professionals, and you would know this based on your work in the paramedic community, but if you work in the pharmacy community, if you work in the nurse practitioner community, the level of excitement, the level of progressive ideas, the energy in those communities is amazing. And there is a huge policy shift taking place across the country, but there are professions stepping up saying, don't look at this issue narrowly. And that's part of my submission here. It is not simply a physician supply issue. It is, how do we make the shift to collaborative care? How do we do it with community support? And how do we build on a tremendous momentum that exists? And I've seen it in this province. I had a nurse practitioner sit beside me at a talk that I was attending, and I mean, you had to contain her in her seat when you asked her what her ideas were. So that's a general comment, but you wanted more specifics, and I'll ask the authority to address that.
Ms. Knox?
Thank you very much. I want to thank you very much for that question. And for us at Nova Scotia Health Authority, it is about really saying we need to take the time to do that well. And as you described, that was the change in terms of the development of the CECs, the professional, the team engagement in planning what the service might be, and engaging with the community about what they wanted and what their experience needed to be. So I'll ask Tricia Cochran to talk to you about what our engagement is about.
Ms. Cochran?
Thank you. And I would say we are pretty pumped and enthusiastic about the support that has been provided by providers around the province. This is not a matter of convincing people, our providers, that they should, and the population needs us to work in a collaborative team-based approach in the community. They've embraced that. So in the first couple of years that we've been an organization, I'm going to start there, we needed to look at where is our physician leadership, because physicians want to talk to physicians, right? The rest of us are interesting for them, but it's really they want to talk to other physicians. So we took some time to begin to put a structure in place where we've got physician leadership in Nova Scotia Health Authority from a physician perspective. So in our 4 zones, the new geography for Nova Scotia Health Authority, there are 4 physician leaders. They are practicing family physicians. So it's not as if they are not aware of the practical issues in a practice. So that's taken some time to get them in place. In the last, I'll really focus on the last 6 to 9 months, after some initial evidence gathering and planning happened, the chiefs, along with our primary care directors, so we have a co-leadership model in our organization, they've met with, we can formally say, well over half of our family physicians across the province. In an informal way, they're talking to physicians day in, day out. That's their day job. So that is occurring. But in a formal way, there have been forums to talk about collaborative teams and what we're calling a health home model. So what's the difference between a team and the model around health homes? And discussing with family physicians, what are your questions? What are your concerns? What is your advice? So that's been happening in these geographies. 14 or 15 sessions happened just last fall. That, in combination with some forums or focus groups, one hosted by Doctors Nova Scotia, which was a webinar format, 60 family physicians, that's not small, who attended that, and that partnership with Doctors Nova Scotia. Again, we're committed to working with Doctors Nova Scotia on this, and our primary care leaders and Lynn and I have met with them, and we're now at the stage where we're thinking through, and what is our joint role? So that has happened. There's a newsletter that's been initiated, and good response to a newsletter.
Okay,
So,
I appreciate that. We do have limited time,
Yeah.
so there is some consultation with doctors. And you said, and I think you mentioned about time. Time is needed to make sure we move forward. I can agree with that, but with all due respect, the issue in front of us is that there are Nova Scotians without a family doctor. There are Nova Scotians without access to primary care health care. There are Nova Scotians who are falling through the crack every single day. And there comes a time when the government needs to make a decision. And I haven't seen any timelines from this current government. We hear from every now and then in the media, it could be 5 years away. We don't have 5 years. And I don't believe that it would take 5 years to get these up and running. We have an example just down the street here, the North End Community Clinic, that have been running since, if I'm not mistaken, the 70s, maybe the 80s, but I think the 70s. Very, very successful. So I don't buy the idea that we're going to take 5 years, the government's going to take 5 years, because Nova Scotians don't have time. It takes a government to make a decision saying this is how we're going to go about it. There has been countless studies and information on how collaborative clinics are the way that we should be going in not only in our country but across the globe. So it's going to take commitment. So where are those timelines? I have to say, in our mandate of 4 years, within 3 years, we not only did the consultation with doctors, consultations with healthcare workers, consultation with the communities, and then opened 8 collaborative emergency centers in 3 years. We're 3 years now, and we're still talking with physicians, and I respect physicians immensely. They're a key component to delivering primary health care. But if we're going to approach it in a collaborative way, there needs to be a timeline to say, okay, we've collaborated with the physicians, we've collaborated with nurses and pharmacists and other people who are going to be involved in this. We need to consult with the community. So when is that going to happen? Is that going to be 5 years from now? So it's very frustrating to be on this end, to continue to hear this is what we're going to go to solve the problem around physician access to physicians and access to primary care. And Nova Scotians don't have the time. So maybe I'll ask the deputy, is there a timeline, a hard set timeline, when we're going to see the first new collaborative community clinic, or whatever the term is going to be, because I'm sure there's going to be consultation on what's the right name for these clinics. When are we going to see, and when is Nova Scotia going to see the first clinic in Nova Scotia, so that we can get on with ensuring that Nova Scotia has access to primary care? Can you give me that timeline, or is that premature?
Ms. Parrott?
Thank you. No, I can't give you the timeline that you're requesting, but I do appreciate your comments around the need for that, and I think there's been a lot of change just in the move to One Health Authority, but also in the role of the department, and that is up there in job one of the type of measures we need to put into place. But I do want to say this, and I'll ask the authority to correct me if I misunderstand it, because I do want you to understand the progress that's underway. When I say there's foundational elements, I'm not speaking lightly. There is a lot of planning for where community collaborative care clinics needs to go. There's a tremendous amount of information and data that we've never had being put into play to plan for those clinics. And we need roughly, my understanding, 78 clinics in the province today. And we have underway 42 that are in various stages of standing up. So I say that because I want you to understand that in this shift, and it's a structural, cultural shift, there is momentum and we have some traction. And so there is positive movement forward.
And I would say that, especially in frontline healthcare delivery, in professionals that work in the community, they're in. There's buy-in. There's been buy-in for collaborative approach to healthcare delivery for 25 years in this province. So I don't think we need to waste a lot of time on that aspect. I think from physicians right down to pharmacists are more than willing to step up to the plate and ensure that this new approach is going to happen in the province. You talked about where these might be. We know and we heard in the fall that the community of Weymouth, for example, had a retiring physician, and that there was a plan to replace that physician, but the authority had advised them that there will be no billing code given to the community of Weymouth. I still don't understand why that has taken place. I have a number of questions. I know we're limited on time, but has there been other communities identified like Weymouth that will no longer be issued billing codes? I know that the Central Region has restricted family physician licenses, to try to address the collaborative clinic. I see the physician shaking her head, but I read the policy. There was a restriction there. So I asked the deputy: is there other communities identified like Weymouth that will no longer be given a billing code or restricted? Maybe down the road they'll be giving it. I don't know if that's the intention. Is there a number of communities that have been restricted for like Weymouth? And can you provide that list to us?
Ms. Parrott?
So the Health Authority is leading the recruitment effort, so I'm going to turn this question over to them so you can have a specific answer.
Ms. Knox?
Thank you very much, and I'm going to ask Dr. Harrigan to address this.
So thank you for the opportunity of correcting a lot of misinformation that's out there. There are no restrictions of billing numbers in Nova Scotia, period. But every physician who comes to work in Nova Scotia must be privileged. We have a plan so instead of actually planning for what providers want, we're actually planning for what the people want. And so we have to turn the system on its head, and we're using lots of information. We know the clusters, we know the community status of where our places should be. We know that physicians don't want to work in solo practice. If we want to speak specifically to the Weymouth area, they tried to recruit there for 2 years because nobody wants to work as a solo practitioner. Our goal is to build with communities a plan for the future. And so we actually have built with communities. So we actually have a group, Digby, Weymouth, Clare. We're all working, community members, the wardens, the government, our health authority, to plan what we need for the future to serve all those citizens. And everyone is in agreement. And so what we're trying to say is, we want to avoid one-offs, popping someone in, and in 2 years we have the same problem, or building a specific foundation for primary care that's sustainable into the future.
But wouldn't that help the thousands of people without a doctor currently until the system is ready to accept that? And I must have dreamt Dr. Saab coming to my office, who was looking for another billing code to expand his practice and was denied, and I brought it to the floor of the legislature, and then he was given the license. I must have dreamt that, Mr. Chair.
No,
so
it's a terminology thing, and I think it's important to correct, because no licenses are restricted in Nova Scotia, no billing numbers are restricted. He was asking for a new position. And so from an accountability perspective, what we have said as a health authority and as a government is every position that's currently here will be replaced. But remember, our current system isn't planned. There's no planning in our current system.
Well,
but we need to maintain it.
we're not doing a great job if we only brought 36 in and we have 27 vacancies in Halifax or Central alone. I mean, that's not a great record, and I can't understand why if Weymouth, if a physician, if they were able to find a physician tomorrow, would the government approve that? Would the health authority approve the ability for a physician to go to Weymouth just in the interim until these new
what we would approve,
but we have to move on to the next round. We'll go to the Liberal caucus. We're going to go to Ms. Lonis Croft.
Yes, thank you. Would you like to finish that comment? Dr. Harrigan?
Harrigan?
Yes, I would. We have been working with the three communities, and we have a plan to create a collaborative base in Digby, and those physicians in that practice will service the Weymouth and the Weymouth area, and will actually be present in the community. And that is something we've worked together on. It's a group of physicians as part of a collaborative that we think is sustainable into the future, and we think it's something we should actually celebrate.
Okay. Thank you. So we've heard lots of questioning about doctor shortage. Is it a crisis here in Nova Scotia on doctor shortages? Who wants to answer that?
Ms. Perrin?
So I would say, no, it's not a crisis. And that's why I laid the context about giving you a national perspective in which you have you'll always have some gap in who wants a family physician, because not everyone, quite frankly, not everyone wants one. There are some people that are quite happy to have walk-in clinics and have the convenience of that type of service. But there is, based on every study we've seen, a steady supply of physicians across the country and in this province. But the shift that's taken place on how we use that resource and how many we need when we move into a collaborative care environment is the central discussion. If we just say, let's keep doing what we've always done, let's just replace the model that we've had, then I have to circle back to you to say, well, when Canada's compared internationally, when Nova Scotia is compared internationally, we don't have the health outcomes that other countries have. So just doing the same isn't giving us better health outcomes for our population. And that's the motivating factor behind reorganizing how and where we provide care. And that's a huge effort. I mean, as you've heard the comments, we have a system now that's, and across Canada, that is largely unplanned. Physicians have been independent providers. They are private practitioners. They set up businesses. They decide where and when to work. It's been in an unplanned context. And we're coaching that system into a planned context, into a much more supportive context, and we're including new health practitioners in it. And we're doing it in a responsible fiscal manner so that it's not just, and this has been a curse of the healthcare system in Canada, ad hoc incrementalism. This is a restructuring that is carefully planned and focused on improving outcomes for patients.
Okay, so it seems to have come to a head. You know, it's in the news, as one of you said, regularly, the numbers or the shortages. But this isn't a new problem. So what's changed? Like, what has happened? You know, how long has this been going on?
Well, I think if you read some of the reports, I referred you to the Dr. Naylor report. He would say we have to change the way we deliver primary care. We've known that for a long time, and he's the one who makes reference to the 70s, where we knew how valuable a resource we have in nurse practitioners, but we never included that resource into our delivery system, into our publicly funded delivery system. So we do have a large body of research information, of evidence, of established practice that tells us collaborative care is the way to go. And as I said, in this province, there is very good planning underway. There's a realization that we need around 78 collaborative practice, and 42 are in process over a relatively short period of time. If you compare that to some of the other provinces in Canada, I think Nova Scotia would compare very positively, and you'd see momentum here to a greater degree than you'd see elsewhere.
Okay, thank you. And other members have mentioned, you know, I regularly get calls at my office. Someone, their physician is moving or retiring, or some people, I'm amazed, just don't have a family practitioner, and they never have. And you know, and it's not until they have a health issue that, oh my gosh, I guess I need a doctor. And I'm finding that a frequent response I get when I say, well, what happened to you, doctor? And they say, well, I never have had one. So what do I do? What do I tell people who call my office and say, help me find a doctor?
So I'm going to refer this to the Health Authority that's managing that initiative.
Ms. Knox?
So thank you very much. So it's a real issue, isn't it? And you're identifying in terms of those people we don't necessarily know about. So with the help of 811, we have developed our process of finding I need a family physician as a way of getting some real information. So I can let Dr. Harrigan, who led this initiative with our primary care folks, talk to you about how people use that. We are encouraging people to use that line.
Yep, thank you for the question. I can say I've been in this business for 10 years, and recruitment is a day-to-day job. So for me, this is no different than it's ever been. The patients who don't have family doctors currently might not be the same ones that I dealt with before, but there's a constant ebb and flow. And because residents finish their training in June, largely we get our new doctors in July, August, and September, so often there is a gap. But there have been numbers thrown about everywhere, and it's really important to get some accurate numbers. And so we compiled all the previous lists that were kept from previous health authorities, because previous health authorities kept lists of patients who did not have family doctors. We combined those, and we also created the 811 number so people could call in or go online and register as someone who needs a family practice. Critically important, because you can look at polls, you can look at numbers, and you can say it's 100,000, but all we know is these are real people with real postal codes. And from a health authority perspective, this is how we plan our recruitment. We now know the areas based on the 811 that are areas of greatest need. There were not surprises there for us. It helps us focus our recruitment. For instance, there is an issue in Central Zone that had never happened before. And so we've actually hired a full-time recruitment officer for the family practice in Central Zone. There used to be, we actually pay for site visits for people to visit other parts of the province. We've actually now included that for Central Zone, so people can come to Central Zone and do that. So that's step one, is to get the numbers. Now, are the numbers right? I suspect not everyone's phoned in. I would use this as an opportunity to encourage everyone who is seeking a family practice to please phone this number, because when new physicians come into communities, we will be handing the list of people in that postal code to these doctors to take on these patients. So it's critical that people get on this list, because that is the fastest way to get in. The one part that concerns me is that there is a small portion of people who really cannot be without primary care. They just can't. And these are people who have active cancer, people who are undergoing palliative care. These are the people who keep me up at night. And this is a very complex process to try to filter out who actually needs a doctor right away. And so we are taking this on as our personal mission to create a bridge for those patients who really cannot be without a family doctor until we can actually find them one. And that will be one of my major missions over the next 2 or 3 months. But I have to say this, I don't have a family doctor. Okay, my family doctor retired and has not yet been replaced. Now, let's be honest here. I know a lot of doctors. I know some that are up in the lobby right now. I could actually pick up the phone and get one because I know them. But I've chosen not to do so, and I've chosen not to do so for one very precise reason, and that is I need to be sure that the system we put in place is actually working. So it is my full expectation when a family doctor now joins the Wolfville practice in the area where I reside, that I will be receiving a phone call that I am now part of a practice. And it's one way of making sure that the system is working, because I'm going to go through it as all our patients are going through it to get a family doctor. It's a huge commitment for us, but we're finally on the path with having numbers that are important for us.
So do you go to a walk-in clinic, or do you see one of your friends?
I go to a walk-in clinic,
Okay.
and I go to Emerge and I wait my turn.
Okay, because that's another question I had. What do I, when people say, my child has an ear infection, I need a doctor to look after. What is the advice that you give people waiting for a primary care giver to, what do they do when they need to get prescriptions filled, for example?
Still me? Okay, so first you can call 811 because in addition to taking names for people or family doctors, there are nurses on the line who can provide you with advice. We do advise people to use walk-in clinics or community clinics or emergency rooms as necessary. It's not ideal, but they can refill prescriptions. They can provide advice, but unfortunately, they will not provide you with continuing care, which is the beauty of a primary care. But it can be a bridging measure until such times you have a primary caregiver.
So someone who has a chronic illness or is a cancer survivor but needs regular checkups, would they also go to like an emergency room? Or
yeah, that's the group that I talked to you about.
Yeah.
That is as of concern. We need to find a solution for those people, because when many family physicians retire, they identify these groups. I was talking to a family physician recently. She had 1,500 patients, but she identified 100 that really could not be without a family doctor. But she arranged for another doctor in the community to take those ones on. In the circumstances where that does not happen, we have to have some kind of process to triage those patients and to support them until we can get them into a
yeah, OBS must be a concern too, or will the IWK Grace look after those people, or?
Pregnant women are generally cared for, not necessarily by the IWBK, but by obstetricians throughout the province. Yes.
Okay, thank you. I did want to go back to, there was a comment about the study that included the nurse practitioners. I see them as the saviors of the healthcare system. I myself see one on a regular basis, and I'm very satisfied with the healthcare I've received. I hear from people all the time, oh, I know someone who's a nurse practitioner, and she'd love to come to Lunenburg or Mahone Bay or whatnot. So why does it take so long to fill these positions? Like, why are we waiting months, or maybe a year for a position to be filled?
Ms. Knox.
Thank you. That's a wonderful question, and it's about our how do we hire the folks. And so Tricia Cochran is leading that process for us. I'll ask her to respond.
Ms. Cochran.
So we appreciate very much a new investment in the last number of months to hire up to 22 nurse practitioners and 22 altogether nurse practitioners and registered practice nurses for teams. So there has been a great deal of effort go into how do we decide where we most need them. So we've looked at the criteria that's required. It's a combination of access. So where are we hearing the biggest gaps are? The demographics of a community, the age of a community. So if it's so looking at a number of factors that help us determine where we should put that investment. And there has, after the criteria were developed, there was a team of folks, including family physicians, practice nurse, nurse practitioner, members of the public, who sat on the selection panel and determined where those communities, where those positions would go. So that finished, and when those decisions were made, we had 45 applications or expressions of interest from practices. That's not that's something to celebrate. So there is real interest among physicians to do this, and through the selection process, determined which were the practices that we were going to further discussions with on those positions. So that has taken some time. And then once we nail down, these are the practices where the new providers will go, the positions will go, then we have to work with those physicians and determine every practical things. Is there space for those new providers? What is the collaborative care arrangement going to be? You want me to speed up, I think. So there's been it takes time, and we're in the stage now where the physicians have signed off on an agreement to say yes, we're in. There are a couple that we're still working on, and those so we're solid. We know those practices are going to be welcoming environments. And now the positions have been posted. We've posted them province-wide, so that instead of hiring in one location and then the person saying, oh, I'd rather go to the posting in the next location, we've said we're hiring them all at once. It's complex to do that, but that's where we are. So the positions have been posted, the screenings have happened across all of these positions, and now we will be into the interviewing.
So how many nurse practitioners are we graduating a year here? Is it just Dal that does the nurse practitioners?
Yes.
Program? Okay. How many are we graduating a year?
I don't know the answer to that. Yeah. We have had interest.
Okay.
That hasn't been an issue.
But to me, an easy solution would be to open up the program to take in more people interested in going into nurse practitioners who, I know we've talked about, helping doctors with their tuition fees and whatnot. To me, it seems only logical that we would open up more placements for nurse practitioners in their school.
Well, we'll have to look at the supply versus the demand. For nurse practitioners, they don't only work in primary care. I would also want us to not forget the practice nurse positions. Okay. Those are very, very critical positions. Chronic disease management, that requires a lot of attention. We need to manage our disease with the help of a health system. And so there's a lot of work to get us there and to manage it well. vehicles like group education sessions for blood pressure, we need some new ways, some more efficient and effective ways in our primary care system to deliver care and support. So that's built into, so the teams need to think about what roles and skills and what's our population need and how do we best do that. So that team of people need to sit down and figure out, this is our population. What's the nurse's role? What's the nurse practitioner's role? What's the physician's role? And they do it as a team. Guidance, yes, but as a team. And then they will be developing an accountability document with us on that, how they're going to serve the population. Okay. But it's the whole team that is the magic.
And I spoke a little bit about incentives with the med school. What tools are you using for recruitment and retention of doctors to get them here to Nova Scotia?
We go with who would like to respond? Ms. Goldrin?
So at the Department of Health and Wellness, we have a number of programs. We have return to service agreements, and the communities of need are identified in the province. So we have those. We have a family medicine bursary. We have debt assistance, and we have tuition relief.
Okay, so those are being well taken up in Nova Scotia currently?
So as an example, last year we had 18 communities across Nova Scotia where those programs put physicians into those communities on return of service agreements.
Okay, and return service means?
So return to service means the physician signs a contract and they provide service to that community for a number of years.
Okay, thank you. When you are recruiting, I know there are lots of communities. I know I have one that has their own recruitment group trying to find a primary caregiver. Is there collaboration between Dr. Harrington, your group, and these groups? I mean, I get confused sometimes because I'm not always sure which one is doing what. Would you like to speak to that?
Dr. Harrigan.
Sure. I mean, we know, and studies will prove that working with communities and helping to recruit people is absolutely essential. And we're working very closely with communities to do that, and would encourage anyone who's looking into recruitment to talk to us about it. I think what we actually know that the tendency is to provide income incentives to people, but in fact what we found is actually much more valuable, and I think the literature would show that, is to create a welcoming environment in your community for the people who are coming. We have spouses who frequently need to be employed. We have school systems that the children are going into. We frequently have people who may be of a different cultural or religious background. We need to welcome them with open arms. And where we've been successful is where we've mentored members of the community with the physicians coming in and making them feel part of that community. Absolutely essential, happy to work in collaboration with all communities, but that is the key, is to make the physicians welcome and part of the community that they're joining.
Okay, did you want? I'll pass it along to my colleague.
Mr. McGuire.
Just a quick question. Back to the nurse practitioners. In December, we made an announcement of 22 nurses. When will we actually see those nurses in the communities? And I don't want to talk about the whole system, and I just want to know when will, because one of them's going to Spryfield, when will we see that nurse in Spryfield?
Ms. Cochran.
Thank you. So we're in the hiring process now. For all 22 positions across the province.
Roundabout date, like time, months, are we weeks, days, months?
They will be hired between now and the end of April,
okay,
and be in place this spring.
Thank you.
Thank you. We'll now move back to the PC caucus. Mr. Houston for 11 minutes.
Thank you, Mr. Chair. I do have just a limited time, so I have a series of questions. Hopefully we can get some brief answers to it. But Dr. Harrigan, you mentioned that since you don't have a family doctor, you said you either go to a clinic or go to Emerge. And I think that a lot of emergency room physicians I know would kind of cringe to hear that, but that's what's happening. So I would like to ask the health authority, I've seen some statistics on the number of visits to emergency rooms, like for 2015, 2016, I think it was about 78,000. Just like to ask if the department can provide in writing, maybe even by the end of the day, the total number of emergency room visits across the province by year, since 2009. So just for the last 7 years, how many people are going to emergency? I suspect we'll see that ramping right up, but I'd like to see that from the data if we can get that. That's one thing. And in terms of the, is that okay? Is that something we can get? Emergency room visits by year?
Ms. Parrott?
Thank you. Thank you for the question. We'll see what information we have and put something
Okay, thank you. In terms of the nurse practitioners and the family practice nurses, 22 of them, there was additional kind of budget allocation, $3.6 million. Was that $3.6 million for this fiscal year, for this year that's ending in a few weeks?
Mr. Elliott?
That's the annual total cost, but that won't be spent this fiscal year because, as Ms. Cochran indicated, they're not all going to be filled this year. That will be the annual cost once those positions are all in place.
Okay. Has any of that been spent? Do we have any of them? Do we tap into any of it?
I'll have to ask Ms. Cochran if any of those positions are filled.
Ms. Cochran?
I explained earlier that we're doing this as one fell swoop. Posting across the province,
so the
doing the
allocation
selection across the province, doing the interviewing.
Sure. Okay. No, I just wanted clarification on that. So, so the minister made the announcement. It was a well-received announcement. It was a lot of fanfare around it, but not a penny's gone out the door yet since then. That was quite some time ago. Okay. All right. On the interest of time, I'll leave that. It does seem bizarre to. If you get one, you should put them into play, I would have thought. But if you're waiting for all of them at once, I guess that's a decision for a higher pay grade than me. But I do have in Ontario. In Ontario, they're talking about allowing registered nurses and nurse practitioners to prescribe certain medications. Is that something that we're looking at doing here?
Ms. Goldring?
It is something that is being examined right now, but it's under active discussion in our department.
Okay, so it's being looked at, but there's no decision. Are you aware of any other provinces that are doing it?
I'm not. But
Okay.
I'm not. It doesn't mean that they aren't. I'm just not aware at this point.
Okay, seems like there might be a role for that, but it's being looked at. Okay, and we talked about transitioning the system to turning it on its head. I think I heard was one thing, and all kinds of different things. But in terms of community-based healthcare and people taking more responsibility for their own healthcare, I'd like to ask: Is there any physicians play a role in that? I often hear from physicians that they just don't have time to try and work with people as to how they can be healthier. They just got to get them in and out and try to see the next people. But is there any kind of a billing code that a doctor could use if they were to see a patient and try to work to them on a healthier lifestyle thing? Could they do it? Is there a billing code they could use for that?
Ms. Goldring?
So are you talking about a code just for a physician to talk about a healthy lifestyle with the physician?
Yeah, to work with somebody to improve their own health outcomes.
We have a number of codes that would cover that. A specific one just to discuss a healthy lifestyle. We have complex care codes. I think in a general office visit code that we have with the physicians, they can have that discussion with the patient. A code exactly like that, I'll have to check for sure
So they
for a
could work
well-being code. But
they could maybe work it into a code, I guess, is what you. But I wonder if maybe you should have a specific code. Then you guys could track how many times that, if you're trying to move the system to people taking more responsibility. I don't know if that's the way to describe it, but people being healthier. Because the doctor did tell me that he said, like, Tim, as a politician, you have way more influence on a person's health than I do as a doctor, because I have to deal with what's there. But I don't have much time to invest in prevention. So if you had a code like that, I know there's a code review that was started a few years ago under the NDP. Is that review still happening?
yes, it is. So that's the Physician Manual Modernization Project. PMMP, and so that is still underway. And so physicians are actively engaged in that project with us. And
Do you
are
have a timeline for that?
Yes, November of this year, we expect to have
So in November of 2017, a report would come out? Okay.
Well, not just a report, we expect to have the new manual available in Nova Scotia for physicians to use.
New billing codes? New billing codes?
Well, it's looking at relative values. We're trying to get away from that terminology of billing codes. So what the manual will look at is the real way that physicians practice now. So exactly what you're talking about being able to provide payment to physicians for taking the time to have those discussions with the patient on their well-being and their care and what they can do on their own. The manual will recognize those types of care, that type of care, and it'll be in the manual.
Okay, so November 2017.
Yes.
Okay, I often hear from people who say they had to go to province to see a specialist or to have a surgery. They couldn't get one here in a amount of time. They could get one in New Brunswick or somewhere else in a much shorter amount of time. I guess I'd ask the deputy, is that just anecdotal or is that happening? Are Nova Scotians going to other provinces to get care quicker?
Ms. Parrott?
So I'm going to give you a general answer, and I'm taking a bit of a leap.
Maybe could we be as specific as yes or no? Are they going to other areas to get care?
I was going to say that, all provinces have arrangements where our members of the population can go to other provinces to receive various services. I don't know the number in Nova Scotia, and certainly I do know there's a number that come into Nova Scotia to get services as well.
Maybe I could ask for those numbers. How much has the province, maybe we have it to hand, how much has the province paid to other jurisdictions in transfer payments to cover the cost of Nova Scotians going to other areas to get treatment? That'd be one part of that. The other part of that would be, I guess, how much has Nova Scotia received from other provinces, and then we'd have a net amount. Is that something that we could get? Is that a number we could get?
Mr. Elliott?
Do we have it to hand?
I don't have it right now, but I can tell you that Nova Scotia has for a long time been a net recipient. We receive a lot more than we actually pay out. So that number is a significant number in the millions more that we receive than we pay out because of our Atlantic presence.
Sure. Yeah, I imagine, yeah. So we could get that chart, maybe it could provide some level of detail on what services people are leaving the province for and coming in. Maybe could we break it down like that by service?
I don't know if I'll know why they left. Just be able to, I'll see what we can get.
Okay, thank you. I wonder if we can get, if we can ask about the VG. What's happening with the VG replacement? Where are we at with that? We've seen monies announced and pictures taken and stuff, but is there actually, what can Nova Scotians expect to happen with that?
Ms. Parrott?
I'm going to refer the question to the Health Authority.
Ms. Knox?
Thank you for that question, and it is an important question for Nova Scotians because our QE2 Health Sciences Centre is a Nova Scotia resource, and in fact a resource for Maritime Canada. So we have a very aggressive strategy in terms of, as you know, we need to decant the VG site, those two wings of that VG site. And so we are we have gone through a process, and we're now at the process of design of the space that needs to replace those two buildings.
So the design is done?
No, it's not done. We're in the process, and that'll take about a year.
So another year for design.
But in the meantime, as you know, we have created a solution to the services that we provide there by enhancing services at other sites, and it is our approach to not be centralizing all services in one place, but put them in the place where Nova Scotians can access them. And so the Dartmouth General Hospital is a very important part of the work that we're doing and enhancing, adding 44 new beds there and new surgery suite, and that work is well in development. And we're in the process of finishing the design for the work that will be done at Hants Community Hospital, and we'll have that work done in the next months. And so that's really important.
Thank you, Mr. Houston. We'll now move to the NDP caucus, and Mr. Wilson.
Thank you, Mr. Chair. I just want to quickly return. I know my time was cut off, and Dr. Harrigan was answering a question around Weymouth. So I just want to be clear. Dr. Harrigan indicated there was no restriction on billing numbers, but I believe I heard if the community found a physician that they would not be granted a billing code. Did I hear that correctly? I know. So if the community physician of Weymouth found a physician tomorrow to fill the gap until we have a collaborative model in that area region, would they be allowed to practice in Weymouth?
Dr. Harrigan.
Right, it's just the billing number thing. Everyone says billing numbers, and it's always wrong, okay? So, but what we have said as part of the Nova Scotia Health Authority that all physicians are in. So if you want to work in Nova Scotia, you need to be privileged in the Nova Scotia Health Authority in order to obtain, if you want to utilize the resources of the Health Authority, which are lab and DI, you must be privileged. So,
completely understand that.
Right,
Yep.
So what we would say, because of our planning, because we are planning with the community of Weymouth. So I know not everyone in Weymouth is happy, but we are working with the community of Weymouth. We have the warden of Weymouth, our committee, and our plan is to put a collaborative practice in Digby with satellites to Weymouth. We would not grant privileges to someone to work in Weymouth.
So it doesn't matter if it's billing code, that's not my term, a physician, a doctor, a medical person. So I understand, no, they would not be allowed. I understand.
We would encourage them to come and work in our collaborative, which they would want to do.
You would encourage them to go to Digby once a clinic is open, when we don't even know that. There's no timelines. That's what's the frustrating part, not only for us, but for people in communities like Weymouth. The deputy mentioned there was about 42, I believe 42 possible clinics, sites. None are open right now. We can't get when they're going to be open. Could you provide the list of the potential 42 sites in the province? Is that something you could share with Nova Scotians?
Ms. Parrott.
So there's 42 that are in play, either stood up or in the process of being stood up, but the Health Authority will have more specific information for you.
Ms. Cochran.
It's not one size fits all. Over the last 10 years, the funding that has been available to enhance and begin to build collaborative teams has been one position at a time. So we have partially funded or part clinics or part teams that have formed. And so part of our work is going to be to build the new collaborative team members to those 42 teams, continue to work with them on what we call quality improvement, looking at their patient population and figuring out with them and with their teams how to best serve that population. So those teams are in one way or another already in shape. And we have about 8 that we would consider are pretty much the team is there. And now we'll continue to work on how we offer quality care for the population.
So that didn't answer the question. Are you able to provide us where those teams will be working?
Yes, we can give you a list.
Excellent. You indicated there's 8, but already there, or the team is together. And I couldn't agree more that not one size fits all. That was the key to implementing the collaborative emergency centers. Each one was different because the community needs were different. So this is not a new concept. That's the frustrating part about this, is that has happened 7 years ago, 6 years ago. We understand that. Communities are in need. And I would say because of the amalgamation of the District Health Authority, maybe the delay is because each community's voice is lessened because of the amalgamation. And I know maybe there'll be a difference of opinion, but I truly believe the reason we don't have a hard dates on when these collaborative emergency center or collaborative centers, clinics, models, whatever you want to call it, aren't open is because of the loss of that community input. I'd like to go to quickly to the VG replacement. I know my colleague mentioned it. Just a quick question on, is the Cobequid Centre in Lower Sackville being considered for expansion to offer some of the services that will be displaced from when the closure of the Centennial and the VG site.
Ms. Knox.
Thank you for that question. It will definitely be one of the areas that we would be looking at, yes.
Okay, great, thank you. And I know we don't have much time. I want to go quickly to the recent follow-up from the Auditor General's report. I know that there's a number of recommendations that had not been completed, and in the report they identified those. And I know there was a response from the department and from the Health Authority. But one area I know that was a bit frustrated for the Auditor General was around even just trying to find out if the department, if the Health Authority, if the government is committed to meeting the national benchmark for hip and knee replacement. How come the Auditor General couldn't get a response to that? And so I'll ask that now. Is the government committed to meeting those benchmarks for knee and hip replacement surgery wait times?
Ms. Knox.
So I'll speak on behalf of the Health Authority, and I can say the answer is yes.
Yes. So is that a commitment, like that the province has agreed to meet that? Is there a plan in place to reach those goals?
Would you like to hear our strategy?
No, I'd just like a timeline, really. The strategy is fine. I mean, the strategy of trying to do more surgery is ultimately that's what the goal is.
So
is there a timeline on meeting the national? That's the most important thing, really. Is there a timeline?
So we have a strategic plan that is a 3-year strategic plan, and it's part of that. That strategic plan would be starting in 16. So we would see over a 3-year time frame that is our goal. Our challenge with the report from the Auditor General is that we had to look at particularly hips and knees. We had an extraordinarily long wait, a number of people who were very exceptional long waiters, and when we looked at our population who's on the waiting list, we decided that our best approach for the sake of the people who are on the waiting list was to focus on the long waiters. That's not how the recommendations would have been. They weren't direct to that. And so we put a target in the first year of Nova Scotia Health Authority to do 600 plus new hip and knee surgeries. We did 675. We put a target for more than 800 in the second year, which we're finishing. We're in our 24th month of Nova Scotia Health Authority. We will have achieved 875 to date. And so what we know that, and for the first time ever in the second year, we have put fewer people on the wait list for hip and knee surgery in this province than have had their surgery, than have come off. So our wait times look worse because the people who weren't waiting as long are waiting a little bit longer, while the people who are the longest on the wait list were having their surgery done. But we describe that process will take us 2 years to really then be constantly reducing our wait list. So it's a very complicated strategy, but thank you very much for giving me the opportunity. It is a major focus for us.
We'll move to Ms. Zan.
Thank you very much, and actually I'm glad to hear that it's starting to move along, because I have a number of constituents in the Truro area who are waiting for hip and knee replacements as well, some that are very complicated, and they've been waiting for 3 years in agonizing pain, just agonizing pain, and they're really, really, really frustrated. So I hope that does move along.
So one of our contributors to being able to do orthopedic surgery in Truro.
Say that again, please.
One of our contributors to getting our wait list reduced is being able to do orthopedic surgery now in Truro.
Right. That will be very, very handy. Thank you. So despite commissioning a report that showed collaborative emergency centers were working, the McNeil government hasn't opened any more CECs, and I don't really understand why. They obviously work, and they were the first of their kind that the whole country was talking about. I noticed that in the 2013 platform, they were, the Now government said that they would insure a doctor for every Nova Scotian within their first year, and at the cost of $3 million. And I noticed that you said you just got $3.6 million from the Department of Health recently. So again, I'm not quite sure why more CECs aren't being opened. It also, in Thursday, October the 2nd, 2014, the health minister stated that the CEC in Lunenburg would have a definite date very shortly. 2015 June article in Cape Breton Post, the minister said he confirmed that CECs would be coming to North Sydney, Lunenburg, Glace Bay, and New Waterford, and a type of emergency room community health center would go to Shelburne. During question period on Friday, May the 20th in 2016, just last year, the health minister said during the health services review, the current clinics and future CECs are part of that review, and I'm looking forward to a final determination on the communities that are on the list as to what will happen in those areas. So again, I'm confused because we are 3 years now into, almost 4 years into the government's mandate, and yet are you telling me that they're now just compiling a centralized waiting list for the thousands of people who don't have a family doctor? When are we going to have the timeline that's going to fulfill, A, the election promise, and B, when more of these collaborative emergency care centers are actually going to be opened across the province?
Ms. Parrott.
So I think a point of clarity, because you've talked about collaborative emergency centers.
Yes.
And we would distinguish those from collaborative care centers.
Okay.
So most of the conversation has been focused on the collaborative care centers and standing them up. So I just don't want to confuse the two. As I mentioned earlier, the use of community paramedicine and the support that that's providing in communities to enhance primary care responses has been fabulous.
Yes.
And Nova
Order.
Scotians should be proud of it.
Time has expired. We'll now move back to the Liberal caucus and Mr. Rankin.
Thank you, Mr. Chair, and very interesting discussion today on a no doubt challenging issue for the province. And I guess I'll just start with asking a question on the VG replacement as well. Just given the fact that there is significant growth outside of HRM, and I'm just wondering, is there any discussion on looking to decentralize like another outpatient clinic or something in that realm? Particularly my interest is the Halifax West region, not specific to my constituency, but that's where the growth is happening, and I'm just wondering if there's consideration given to locating some of the infrastructure outside of the city core peninsula, and more, my question would be specific to that region.
Ms. Knox?
Thank you for the question. Our approach, so the answer is yes, looking at how do we maximize all resources that we have. And I would say the VG replacement is a good example of how we're trying to do business. Let's not be creating new structures if we don't need to. Let's maximize the structures that we have. The VG replacement is a particularly special, requires special attention because in it resides our tertiary, quaternary acute care service, so the highest level of sickness care for the people of Atlantic Canada. So not all services are easily moved to another location, but some have. So we are looking at those services that do not need to be all together in the downtown core of our city. They need to go elsewhere, and so that is part of our planning. Thank you very much for that.
Okay, I appreciate that answer. So just going back into the physician recruitment plan, given that HRM has some vacancies and others that are imminent, the last I looked, it said 30 vacancies and 22 coming up. What is the transition plan on a broad level for those FTE allotments? Are we speaking directly to those people that are considering retirement or have already confirmed retirement? And I think of the clinics that have team-based approaches, not necessarily official collaborative practices, but I would hope that we're looking at working with them to see if they will, stay longer, because that would be have a less burden on the recruitment for new FTE. Do we fully understand what they're looking for in order to stay in the system to help us transition through to that collaborative practice?
I would ask Dr. Harrigan to respond.
Dr. Harrigan?
Yeah, part of, so of April of last year, we got transferred from the Department of Health to us, a provincial recruiter. That has been a tremendous benefit to us. And we realized immediately that we had no recruitment officer for Central Zone. There never had been. And we totally recognized the concerns that you're raising. We also had no idea, because physicians are independent practitioners, and so they didn't really have to tell us that they were retiring or moving on. And so we're now working together. So we have a recruitment officer. She is visiting all the offices of the people who are actually intending on retiring. We have one website with every single position that's available in the province on the website. We make sure they're aware of all the incentives that are available. Also, we talk to all the residents. We make sure the residents know where the positions are, but it's bigger than that because we know what the new graduates want. And so part of the planning is to say we have to create an environment that would be attractive for new residents to come and work in. So that's one of the reasons to move toward team-based care. And so we have many balls in the air looking at this time, but we have better data now than we ever had before, and we actually have a direct connection with our docs as well.
So when you say you know what the new graduates want, I just wanted to understand if that goes beyond just the model of practice, and if we're actually looking at the methods, if it's not, because I understand some of them aren't as interested in the fee-for-service model. So correct. Is there flexibility for a clinic that is looking to sustain itself and is used to having a certain complement of staff? Is there flexibility to say, look, we know in order to keep you open, in order to keep thousands of people having access to primary care, is there an ability to say, yes, we'll approve someone at, say, a salary level or something along those lines?
Right, so we have multiple vacancies in the Central Zone, so that we have plenty of positions available. There's a great deal of interest on the part of doctors to look toward moving towards group contracts or looking toward alternative payments, and we're working together with the government, with Doctors of Nova Scotia and ourselves to make that a reality, and I think that will help. We have some very innovative practices in the province who have themselves developed group practice and collaborative practice, but are struggling because the costs of doing so almost make it not viable for them. We are in active conversations with them to try to look, the way we pay them, the way we support them is different so that we can continue those practices. And those are happening all over Central Zone.
Okay. And what about the doctors that are on a return of service contract? So some of their contracts are coming up for expiration. What's the plan to ensure that the Nova Scotians that have that person as their doctor continues to have a doctor?
Right. So I'll take a step back to say that our hope is when we have people who come to a community as return of service is that they stay there forever. Currently, it's a 3-year commitment. It has been our experience that many of those physicians leave, and so it becomes a little bit of a revolving door. So again, our answer is the same. If we create an environment, a work environment for them, that is something that provides appropriate work-life balance is one part of it. So looking at the environment where they're working. But the bigger environment is looking at the community where they're living. And so the work that we have to do is to make sure that those people who are in return of service positions are welcomed into their community and feel part of the community and therefore want to stay. And that's absolutely critical to us.
Right. I understand that's the hope, but it's not always the case. And when you have a culmination of maybe an FTE that has a return to service expiration and then another FTE that is looking to retire, there's obvious challenge there with trying to keep a clinic moving. And when some of these clinics have thousands of patients relying on it, how can we ensure that they continue to be sustained? And I ask that because I understand the direction of collaborative practices. I'm aware of a clinic that uses a team-based approach and has applied. And although it was admitted they had a strong case, they weren't approved for a collaborative practice model. So how do we explain that to that clinic when our answer is that we're going towards a collaborative practice model? They're willing to play by those guidelines. How do we ensure that they have opportunity to sustain themselves and keep their patients at that clinic?
It's a really good question. I mean, as we build the system, on the one hand, it's a wonderful problem to have, that everyone wants to be part of a collaborative, but we have to move this we have to be methodical about the way we do it to make sure that we have the appropriate accountabilities in place. For those practices, and I've talked to several of those practices, I think we're suffering a bit from our inability. We used to have international medical graduates would come, usually 12 to 14 per year, that would come and help fill spots in our province. And that program is gone, and so, and it has not yet been replaced. And so one of the ways we can work with that is to work very hard with our colleagues at Dalhousie Family Practice to build a practice-ready assessment so we can bring more doctors into Nova Scotia who are international medical graduates. And the other issue is to open up the UK. We now have an ability through the College of Physicians and Surgeons to bring in physicians from the UK and to use those as mechanisms to bring people in to help those practices out until such time as we can build.
So what's the biggest challenge? Because I've heard it's not a supply issue. So you're talking about bringing in more supply. So what is the challenge? Is it trying to find the funding? Because I've seen FTEs approved, but no ability to fill that position. So I'm not getting the supply-demand dynamic.
Yeah, I think the largest challenge, that we have right now is attracting people to team-based care. No, it's not attracting people to team-based care. It's attracting people to replace an older model that people are no longer attracted to. And so our challenge is to build the team so that people will come and work in those environments.
Right. So you articulated your plan for Weymouth. Can you say what your plan is for the Prospect Hatchet Lake area?
Yeah, so I don't know the specific plan for Hatchet Lake. I've been to Hatchet Lake. I've spoken to all those physicians. It's a wonderful environment. We need to assist them with recruitment, and we are in fact doing that.
Okay. And the number was 1,241 doctors in 2015. How many doctors have been hired in the last 2 years since that number was provided?
So the problem is 71 physicians, family practitioners have come, but some of those are replacement and some are new. So I can't actually tell you how the total will change.
So we don't have a net total in the last 2 years to see if we have more doctors today than we had in 2015. Do we have that?
We do. We do have more, but I don't have the actual number for you right now.
But we do have more. So given that number, I would just expect that anyone who has a doctor currently today will not lose a doctor. Is that a correct assumption?
Well, I think the issue is, and it's the constant dilemma. If you look at the actual numbers, which we have, why doesn't everybody have a doctor? Mm-hmm. And the thing is, we don't control how many people are taken into our practice. We don't control how many patients physicians see. And so this dilemma will continue until we establish a system where we actually say, this is your panel size, here's how many people are taken into your practice. That is where we are headed, but that is not where we are now.
Okay.
Order. Time has expired. I'd like to give both the Nova Scotia Health Authority and the Department of Health an opportunity for some very brief closing comments. We'll start with Ms. Parrott.
I would like to thank the committee again for having us here. This is an important discussion. If it does anything, it enhances my resolve on some of the issues that are important to you and to your constituents that we need to be paying attention to. I really appreciate, I've heard a lot of support for collaborative care and for the transition underway, and I appreciate that support. As you've heard, I don't know what the analogy is, but we're building the plane as we fly it. And so it does take some time and care. But I would reiterate that Nova Scotia is really well positioned to make the shifts that are taking place in healthcare systems in the country. And I'm very appreciative of the opportunity to be part of that. Thank you.
Thank you, Ms. Parrott. Ms. Knox.
Thank you very much for the opportunity to talk with you today and for your very good questions to help Nova Scotians understand our issues. Nova Scotia Health Authority is driven by a simple mission: to help Nova Scotians stay healthy and be healthy for generations. It's the foundation of our strategic plan. It's how we are making decisions. It's what drives us. We need different health outcomes for this province, and we have to have the courage to do things differently. So I hope that you're hearing for us. We understand the needs of today. We have to focus on how we help people today, and we need to make decisions that look at all Nova Scotians into the future, and that takes courage. We are working to build a health system that collaborates with communities and care providers, and one that engages people as partners in their own health. What we know is that we have worked together as a province. We have work to do to bring our best assets, and we believe we have a lot of assets in this province and resources to the challenges that we face. And it really is about how we're willing to work together to find the best solutions for our people. Thank you very much.
Thank you, Ms. Knox. Thank you for all of the answers you've provided today, and our clerk will be following up with any answers that remain to be answered, questions that remain to be answered. We do have some committee business. We had a meeting of the subcommittee to choose topics for upcoming meetings. That is before you. Are there any questions or comments about the record of decision from the subcommittee? Hearing none, all those in favor of the topics put forward by the subcommittee? Those opposed? Our clerk will acknowledge that that motion is passed. Those topics are approved. We had 2 items of correspondence, both from the Auditor General's office. Are there any questions or comments about those letters received from the Auditor General's office? Hearing none. Next week we do not have a meeting because of March break. The following week will we return on March 22nd. We will have the Department of Municipal Affairs as a witness. The topic will be financial oversight. Is there any further business to come before the committee? Seeing none, this meeting is adjourned.